Well, I thought today we would say a few words about the larynx um, and try to make it as practical as, as I can. And sometimes we can accomplish that. As medical providers, you need to have a little understanding. This is a beautiful picture of a larynx. I can even see a strand of mucus in the back part of that larynx, so it's a real original in terms of what picture they took. Sometimes when a patient comes and complains about a throat problem, I have a throat problem or I have something wrong with my throat, you want to remember that their description has to kind of be processed by you to try to understand what they're saying. But very simplistically, we have a throat. They may say throat rather than their mouth. I have a throat problem. Well, immediately you should try to think of what does the throat do? What does the throat do? Now, they may tell you something that fits into that, but the throat really does three things. The throat has to be a passageway for air. It has to be a passageway where we can swallow things that are liquid and solid. And our throat, this whole complex of their presentation to you as a throat, we have to be able to talk. Those three things. So we think of the larynx, but actually we should think of the oral cavity, the oral pharynx, the nasopharynx, the laryngopharynx, meaning the hypopharynx and the larynx together. And those are the duties that they have to perform, very simply. You've got to be able to breathe without any obstruction. You've got to be able to talk, or at least have something that's intelligible that you're communicating, and then to be able to swallow. Here's a beautiful picture of the larynx. And probably the main feature of the larynx is not to talk, but it's a sphincter so we don't get stuff into our lung. Because you can live a long life not saying one word, but if you have continual aspiration into your lung, sooner or later, after about the seventh bout of pneumonia, you'll die. So it acts as a sphincter. It has to keep stuff out of that. That's why it's just sort of divinely made in terms of this neuromuscular activity, sensory neuromuscular activity, that can open and close. Open and close, and it does it pretty efficiently. And these are the vocal folds. You see them here beautifully illustrated here and here. They use sometimes the word vocal cords. That is in the medical literature and probably will never be extracted, but you really shouldn't use that term, vocal cord. It's not a cord. It's a fold composed of muscle. And it's attached in front, sometimes called the anterior commissure. It comes back. There's a little structure here called the arytenoid on each side. And this particular muscle, or vocal fold, is called the thyroid arytenoid muscle. But it has a fascinating component to it here in the center, medially, called the vocalis muscle. And they're still studying this vocalis muscle to determine really how does it really work. Well, very simplistically, to say anything with your larynx, what happens is a column of air comes up from your lung, so you've got to have lung function. It comes up, and your vocal cords close, and that column of air sets them into vibration. Now you might say, how does it do that? Well, we're still wondering how it does it this remarkably. It sets the vocal cords into vibration because the column of air causes them to split away and then to come back together and vibrate. And when they do, they can do this at a rate of 125 to 250 beats per second. You can imagine these vocal cords come together and vibrate at that speed. Now they have taken all these beautiful pictures to verify that, and it's just dramatic. And then it it generates vowels, essentially, not words, just vowels. And this column of air comes up and it's modified in the hypopharynx, nasopharynx, oropharynx, where we then use all these other structures to make consonants and make words. It's just absolutely remarkable. And most people think that every voice is distinct, just like fingerprints. No two people have the same voice. Absolutely don't have the same voice. And they're still studying the intricacies of the larynx, but essentially it's designed to open and close to create voice, but it's also designed to close so we don't aspirate. It's an important, probably the most important feature. So you see these beautiful vocal folds. These are the so-called false vocal cords that sometimes can be involved with clinical disturbances, but not very often. There's a little space here called the ventricle, and all of this is rather moist because there's glands there that create secretion, and then your retinoid and these other little cartilages on top. You might say, but where's the esophagus opening? It's back here. You don't see it real well here, but it's closed, and here again through neuromuscular activity. When we swallow, our vocal cords close. What about the epiglottis? Doesn't that tip over and prevent things from getting into our larynx, getting past the larynx? No, you can live without an epiglottis. In fact, there's surgical procedures where we can remove the epiglottis if there's cancer. They have no difficulty in terms of aspirating. It may take them a while to get this coordination together. So we don't aspirate because our vocal cords come together. And then through this coordinated process of swallowing, and the esophageal opening is now patent. The cricopharyngeal relaxes, food slips in, cricopharyngeus closes. Then you have this esophageal peristaltic activity, then get food into our stomach. So just a little sketch of this wonderful structure called the larynx. And so a feature of the larynx that would be real would be an individual might be hoarse. Their voice is husky, and they may not notice it, but someone in their family might notice it. So hoarseness would be something you'd want to investigate, along with all the other features of hoarseness as far as its duration and any of the habits people might have with their larynx as far as abusing their larynx with tobacco or alcohol. But here again, a nice view of the larynx. People often say, well, where's the cricoid? Cricoid cartilage is right here, and there's these tracheal rings. Everyone talks about this space, this cricothyroid membrane for emergency tracheotomies. Well, it's something that you should be able to palpate, and above it you should be able to create an opening there if it becomes a dire situation. But those dire situations aren't near as common as they were led to believe, because of the ability to have emergency people assess patients and intubate them. You much prefer an intubation than to have someone tear a hole through the cricothyroid membrane. It can be done, but placing a tube and providing real good respiratory activity is much preferred than an emergency cricothyrotomy. When trach tubes are put in, they're never put in permanently anywhere close to the cricoid because of what can happen with scarring. Most tracheotomies that are electively done on someone who's been intubated for a long period of time and might need to have their nasal or oral tracheal tube removed. They may be on ventilators for an extended period of time. An elective tracheotomy is done. It's usually in about the third or fourth ring that you can enter safely without encountering too much difficulty. The only problem with tracheotomies is you have to divide the thyroid isthmus, which can be kind of vascular, and you've got to be careful not to have that be a problem a day or two later with bleeding. So going on, let's see here. So here's what happens when we swallow. You know, everything kind of comes together as a sphincter. and it kind of shortens a little bit because it has the ability to shorten itself. You get a real good view of this so-called postcricoid area right in here, and there's a little slit there of the opening of the esophagus. These little gutters on each side act as conduits for fluid and food to come into this area. And once again, if whatever you drink or eat is going to flow over the vocal cords, or if they're closed, they're not going to enter. We've all had little periods that we're laughing and doing something, we aspirate something. Well, it's because there's not tight closure, and things can get in to the area right below the vocal folds. This is essentially what happens when we talk. Vocal cords come together, and that column of air causes them to separate and then to come back together, creating a certain frequency, and that then elicits the notation of pitch. What is the pitch of someone's voice? And another factor is the length of the vocal cords, and also the amplitude of these vibrations in terms of how loud someone's voice is. All these things are studied by people who devote their whole life to laryngeal activity. There's sort of a sub-classification of ear, nose, and throat work. That's all they do is laryngeal work. There's all kinds of fancy cameras and helping people that professionally might need their voice for various activities. Now you might say, what do we see here? Well, we see these wonderful vocal folds, which are these remarkable muscle fibers, the thyroid or retinoid, and then its medial component, the vocalis. And what happens over time, we lose some of the muscle fibers. That's why you don't have 90-year-old opera singers. They can't. Now, they may know music better than a 20-year-old opera person, but they can't sing because they don't have tight closure. You can see the little gap. Sometimes it's referring to vocal cord gaps or a larynx in senescence, a larynx that's aging. Everyone's larynx ages. We just lose a certain number of muscle fibers. People can talk, but they can't use their larynx at an extremely critical level, such as singing. And it's very obvious if you're dealing with professional singers. Some people are, they get older, they're not singers, but their voice begins to change. And it's brought to their attention, or someone brings it to their attention, Grandma's hoarse. Why is she hoarse? Well, it might be just a larynx that's aging, but obviously with the blood work you folks do, you don't miss people that are hypothyroid. Believe it or not, years ago we didn't have sophisticated thyroid tests. You would find people that had these very slow voices that were real slow and function, and lo and behold, they were hypothyroid. That's not a problem because I think every patient is screened repeatedly for TSH levels, so you're not going to miss those. But that was something that was missed years ago. What people do that are hypothyroid, their larynxes work slowly, but they also have this buildup of mucosal material called polypoid myxedematous changes on the cords. But that's a thing of the past now with all these sophisticated lab tests that people get. They're just not something we miss, but you miss clinically. You might say, does everyone that's elderly that has a voice that's changing need to have their larynx looked at? Well, ideally it would be nice to see if they just have bowing of the vocal cords, particularly if they've had a history of tobacco or alcohol use. You wouldn't want to miss cancer on the edges of the vocal cords. I think it's probably a good idea. If from your clinical evaluation they have a pretty good voice in the morning, but by the time it gets to be 10:30 at night, their voice really plays out and they're 85 years old, chances are it's just an aging larynx. But be wise, have someone take a peek at it, particularly if they have any periods where they're aphonic, and particularly if they have any periods when they might be aspirating. You don't want to miss that aspect of the sphincter activity as one gets older. As you know, it's very common. I'm sure that noon today in Nebraska, heaven knows how many elderly people in nursing homes aspirated. It's very common. But generally it's not overlooked. It was in the past, I can assure you. That's an aging larynx. Can you change that? Well, I don't believe you can, although there are people that feel that you can inject this weakness of volume or less volume to bring it closer to the middle. I'm not opposed to that. I don't personally do that and didn't do that when I was in active practice. I'm always worried about putting substances that are not tested over time into tissue, but it's done. And if it stays and it's placed properly, you got more contact with the vocal cord, you'll have a better sounding voice.
What about, my sister's a professional singer, and they used to tell her she would get calluses on her vocal cords, and then she would have to go on voice rest. Can you explain to me kind of what that means and how that presents?
Depending on the nature of an individual's singing and the duration of their singing and also their age, they can have, at the point of maximum vibration, maybe we'll go back and see if I can demonstrate. The point of maximum vibration of these vocal cords, as they come together and vibrate, is at the junction of the anterior and middle 1/3. Vocal cords have, they're in third, anterior 1/3, middle 1/3. The posterior 1/3 has this arytenoid cartilage, so it's called the cartilaginous portion. The singers have the maximum vibration right here. And if that maximum vibration is extremely intense, you can callus this little edge. You might say, what is that edge? That's mucosa, and then right below it, very, very close, is a little ligament, and below that are these fibers of this remarkable vocalis muscle. Well, in the case of a singer, if there's abusive, prolonged activity at this junction, you're going to end up with a little callus. And it's like a callus, when you think of a callus, not necessarily on squamous skin, but on mucosa, you end up with a little bit of fibrous material. Obviously, if you stop abusing the area, it should resolve. They don't resolve very rapidly, and if people have to sing and use their voice, they can become quite frustrated. Because someone says, well, you need voice rest for how long? Oh, maybe for 2 or 3 months. Wait a minute, I've got to use my voice. Now, in your sister's case, does it seem to rapidly go away and she can sing again, or does she make comments in that regard?
It used to be she had to do the 2-month thing, but as she's gotten older, and it's probably because she's learned to live with a voice that's maybe less perfect.
Yep.
So I think she does small periods of voice rest, and she probably has also trained her voice to be able to work differently. I assume you compensate in some way just as you learn over time.
Well, I think you've said it rather well. They learn to moderate what they can use, what they can really do with their voice. And if they're properly trained, they'll not abuse the activity, because it's mechanical.
Mm-hmm.
And if you start abusing, you're going to end up with calluses or nodules or singer's nodes, as they're called. And it does influence the quality of your voice.
Famously happened to Julie Andrews.
Yeah, that is a remarkable case. I'm glad you brought that up. In her case, she was singing this, some of you people that know all about Broadway, it was called Victoria, Victoria or something. Mm-hmm. Maybe you're familiar with that. Mm-hmm. And she really abused her voice. Unfortunately, she was also older. And so she had calluses. And believe it or not, some people in New York, these high-flying laryngologists, said that they could remove those with the laser. Well, I don't know what they did mechanically. But the fact that she was well known, had laser, but never got her voice back, she used that as an avenue to bring suit. Mm-hmm. And to this day, we don't know how that suit ended, except it was out of court, and you can imagine what transpired as far as the financial settlement. They would have been better off if they would have said, you have vocal nodules, you're now 55 years old, just give it up. or change what you're doing, and they didn't.
Yeah, she never's had the same voice.
Never had
It
the same.
sounds like weak, or there's a raspiness that never was the same again.
And it will never come back. Now that she's had some laser, and laser is perfect. I've used it many times. It's very precise, but if you cut into the vocalis muscle, you're going to end up with scar tissue, and that's not going to help you. This whole profession of singing can really be intriguing because of the nature of how people perceive voices of certain people, and how the public addresses that. It's like everyone's voice is different. Everyone has a different resonating capacity. I'm of the belief that people who are good singers, it's a gift from God. They got just the right number of muscle fibers, they had the right neuromuscular activity, and they had this beautiful resonating cavity that came up from the larynx into the hypopharynx, the nasopharynx, oral cavity. And they knew a little bit about music and timing. And a lot of the anatomy is a gift from God. That's why you can't really say, I'm going to go to New York and take swinging lessons and be successful. No, either you have it anatomically or you don't. I don't care what anyone says. We even talked about the medical legal aspects of doing laryngeal work. I mean, that's a famous case.
Yeah.
With Julie Andrews. They lost their shirt, as they say. Should never have done that.